Welcome to Medfoxes. You're watching part 2 of Basics of Temporary Cardiac Pacing, part of our Cardiac Pacemakers, a beginner's guide series. If you haven't seen part 1 yet, check out the link in the description to get the full learning experience. Now, let's continue with ECG manifestation in part 2.
ECG manifestations include when pacing QRS from right ventricular apex shows left bundle branch block with superior axis and ST segment elevation, but right bundle branch block pattern indicate coronary sinus pacing, left ventricular pacing via atrial septal defect or pyrethroforamen well or lead perforation into left ventricular or in pericardial space. Coronary sinus pacing will have a high threshold and absence of ventricular premature complexes. You can say in this ECG, every QRS complex has pacing spike in front of it with a ST segment elevation indicating ventricular is getting paced. In order to confirm which chamber is getting paced, it is mandatory to obtain a 12 lead ECG. The table in this slide shows paced QRS morphology from various electrode positions. When the lead is in the right ventricular apex, the QRS will have a left bundle branch block morphology and the axis should be superior axis. When the pacing lead is in right ventricular inflow tract, it shows left bundle branch block pattern and the axis should be normal between 0 to 30 to 90 degree, minus 30 to plus 90 degree. And when it is in a right ventricular outflow tract, still the QRS morphology will be left bundle branch block with the inferior and rightward axis. If it is in the middle and high left ventricle, it will be right bundle branch block and inferior or right axis. Inferior left ventricular position will give a right bundle branch block pattern with a superior axis, and coronary sinus will also give right bundle branch block pattern with the inferior axis. In order to have a constant pacing, the following parameters are recommended for temporary pacings, which include threshold of minimum less than 1 millivolt, and to check the threshold the rate should be increased above the intrinsic heart rate. It is recommended to maintain 60 beats per minute with output of 5 millivolt and a sensitivity of 1.5 volt. Remember, these setups are always depends on the clinical settings. Like permanent pacemaker, temporary pacemakers also have AAI, VVI, DDD, and VVI pacing modes. VVI pacing is considered first in emergency and during overdrive pacing. AAI pacing is also indicated in case of 6-INS syndrome or in any condition associated with intact AV node. The following features affecting ventricular pacing capture during transvenous pacing, which includes hypoxia, hyperglycemia, hypercapnia. These conditions can be corrected by reducing the drug levels and increasing the pacing output. During MI, when there is a loss of capture, first document adequate catheter position by chest radiograph, then electrograms, which can be corrected by increasing pacing output and possibly lead reposition. In case of poor catheter contact, repositioning the catheter under proper guidance is recommended. Connector problem acutely managed by increasing pacing output followed by emergency replacement of the lead or reposition of the lead. The major complications of transvenous temporary pacing are arterial trauma, air embolism, pneumothorax, bleeding, ventricular tachycardia, and ventricular fibrillation in case of inappropriate T-wave sensing or T-wave pacing, myocardial perforation, and infection for long-term temporary pacing insertion. Overdrive pacing. One of the major advantages of transvenous pacing is overdrive pacing during life-threatening arrhythmias. It can be done easily by single chamber temporary pacing. In order to perform overdrive pacing to terminate arrhythmia, the pacemaker need to deliver faster pacing rate at slightly above the intrinsic rhythm. Dual chamber pacing is effective in case of anterior MI, right ventricular myocardial infarction, hypertensive heart disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, aortic stenosis, recent surgery, if VA conduction with the VVI plus pacemaker syndrome. Any kind of pacing will always have a lot of technical problems. Technical problems are conditions like lead dislodgement, perforation, local tissue necrosis, fibrosis, lead fracture, electrocautery or DC shock which damaging the myocardial tissue interference, generator malfunction. Unstable electrical connections lead to loss of sensing. Most of the sensing problems are corrected by adjusting the sensitivity, changing the polarity to unipolar configuration, and lead reposition. Another technical challenge with temporary pacing is P-wave oversensing. It can be evaluated by observing the catheter tip near the tricuspid valve on chest radiographic and checking the electrogram. The condition can be corrected by repositioning further into the right ventricular apex and reducing the sensitivity. In case of T-wave oversensing, it is recommended to reduce generator sensitivity and possibly reposition the catheter. During myopotential oversensing, make the pacing configuration to bipolar. In case of electromagnetic interference, the grounding of the equipment must be checked. During unstable connections, a fracture also lead to oversensing of either extracardiac or intracardiac signals. Well, next we have a transcutaneous pacing. Transcutaneous pacing depolarize myocardial tissue by pulsed electrical current conducted through the chest between electrodes adherent to the skin. It is valuable and initial mode during emergency, and it is quick, safe and simple. The main disadvantage of transcutaneous pacing is it has variable capture threshold and poor patient tolerance. The transcutaneous pacing require a standalone units with defibrillator, adhesive patch electrodes of 8 cm diameter along with asynchronous pacing or demand mode pacing. In order to perform transcutaneous pacing, the pacing output need to increase up to 200 mA and a pulse width of 20 to 40 milliseconds. Longer pulse width usually lower the pacing threshold. In transcutaneous pacing, anterior electrode is called cathode and placed on the apex or in V3 position, and the posterior electrode is called anode and is placed between spine and scapula. In healthy subject, 50 to 100 percentage of capture is possible, but during cardiac arrest, only 50 percentage of capture is noted. This image shows a typical position of transcutaneous pacing on the chest and back. Next we have a transthoracic pacing. It is one of the controversial technique. As more than 30 years of clinical experience, it can be performed by direct percutaneous introduction of wire electrode into cardiac chamber. It is a faster and simpler technique. One of the advantage of transthoracic pacing is no need for venous access or fluoro. For this approach, RV cavity is perforated and accessed by subxiphoid or left parasternal approach. The complications of transthoracic pacings include vascular or visceral trauma, right atrium or RV laceration, great vessel rupture, stomach, liver, and lung injuries. This image shows the subxiphoid approach to access the right ventricular cavity. Next, we have epicardial pacing. It is a preferred pacing approach during cardiac surgery because it needs thoracotomy. Pacing wire fixed directly into the right atrium or right ventricular epicardium. Epicardial pacing is mostly unipolar kind of pacing. Pacing and sensing parameters will deteriorate with time. Next, we have a transesophageal pacing. The anatomical proximity of esophagus to posterior left atrium makes transesophageal atrial pacing is possible in nearly all patients. This technique is relatively non-invasive and virtually free of serious complications. Furthermore, the technique requires minimal training to perform successfully. However, ventricle capture is inconsistent or often painful, which seriously limits the therapeutic and emergency application of this technique. Transesophageal pacing is now used primarily to terminate supraventricular arrhythmias in patients under general anesthesia or pediatric patients. It has also been used as suitable for pharmacologically proven in stress testing. After temporary pacemaker implantation, the patient needs to be monitored continuously. Daily ECG must be taken if the patient is not being continuously monitored. Daily threshold checking should be done. If significantly higher, lead reposition must be considered. And if there is a undersensing, the sensitivity changes must be resetted or changed. This ECG shows symptomatic sinus node dysfunction in 40 years old lady who underwent temporary pacing in view of long symptomatic sinus pulse. The temporary pacemaker is set at a rate of 60 beats per minute with a sensitivity of 15 millivolt and output of 10 volt. This image shows a Medtronic single chamber pacemaker with a rapid pacing feature setup on the top of the generator. This image shows a typical pacing wire with both ends. This is the end for the this is the connecting end with the distal and proximal connecting port and the catheter tip of bipolar.
That concludes part 2 of Basics of Temporary Cardiac Pacing. To support your learning, we've designed an assessment tailored to this topic. This assessment is specifically created to aid your preparation for the ibhre, CCDS, and other cardiac implantable device exams. Click the link in the description to test your knowledge and reinforce your understanding. Stay tuned for more pacing lectures where we dive deeper into cardiac pacing concepts. If you found this video helpful, don't forget to like, share, and subscribe to Medfoxes. See you in the next one.